Assalamualaikum. But in this video lecture, I will start delivering another chapter of the neuropharmacology, and it's now time for Parkinson's disease. How to relieve, all the drugs that are used for the treatment of Parkinson's disease. Before I really talk about the Parkinson's disease, let's have a little idea about this problem. As you all know, beta, this is a progressive, it's a neurological disorder better studied in neurology medicine part. The triad of this disease with which the patient presents to you, the typical clinical presentation of the Parkinson's disease is number one tremors, right? Tremors and the muscle rigidity. The muscles become quite rigid, quite stiff, and there is bradykinesia. Bradykinesia, that means difficulty initiating the movement. You are sitting comfortably on this chair and you want to want to take a very first step to get up from that chair, right? So to initiate the movement, for you and I, it's really easy to take this step off and keep walking. But for the people with Parkinson's disease, they have bradykinesia. They have difficulty taking initiating the steps, initiating the movement. Along with this is the typical triad. One, the tremors. Number two, the muscle rigidity. Number three, the bradykinesia. This is the typical triad of the Parkinson's disease. Along with this, patient also has some postural and gait abnormalities. We'll better talk about this in medicine, that what gait abnormalities and how the posture is altered, right? This disease is this is a neurodegenerative disease, beta, and it's common in what age group? Over 65 years, right? The etiology behind this is not well defined. It is unknown for most of the patients. For most of the patients, you don't know what is the reason behind they develop the Parkinson's disease. But in some, generally we say the etiology behind Parkinson's disease is the destruction of the dopaminergic neurons in the substantia nigra of the midbrain, right? आपको ये striatal nigral pathway या nigrostriatal pathway, I say, if you remember from the previous lectures of the antipsychotics, you remember from in the midbrain there is something called the substantia nigra, and here top above there is the presence of the corpus striatum in the limbic system, right? Corpus striatum in the limbic system. So what happens is the substantia nigra in the midbrain, the fibers arise from the substantia nigra in the midbrain and they go above to the limbic system, the corpus striatum, just like this. So these fibers are said to be the nigrostriatal pathway. So what happened there is actually the destruction of the dopaminergic neurons in the substantia nigra. So when these dopaminergic neurons in the substantia nigra are destroyed, you think they will release the dopamine here. They will not release the dopamine here, right? So normally what happens, this is the substantia nigra in the midbrain, this is the limbic system having the corpus striatum. The nigrostriatal fibers runs in this fashion, and they are the dopaminergic neurons. Normally they produce the dopamine here, and the dopamine further enters into the corpus striatum and all. But in Parkinson's disease, what is the problem? These dopaminergic neurons are destroyed in the substantia nigra. So once they are destroyed, they are unable to release the dopamine here. Okay, there is a destruction of the dopaminergic neurons in the substantia nigra, and there is consequent reduction of dopamine action in the corpus striatum. Corpus striatum के दो हिस्से होते हैं बेटा, एक होता है neostriatum and one is the paleostriatum, right? Paleostriatum को हम globus pallidus कहते हैं. Neostriatum has got two components, caudate nucleus and putamen nucleus, right? और ये सारे स्ट्रक्चर्स के अंदर जो है ना डोपामिन की सिक्रेशन कम हो जाएगी, ऑब्वियसली बिकॉज ऑफ द डिस्ट्रक्शन ऑफ द dopaminergic neurons in the substantia nigra. When this dopamine is reduced, what will happen? The normal inhibitory influence of dopamine on the cholinergic neurons in the neostriatum is significantly diminished. Obviously, when the dopamine will be released, the cholinergic activity will be increased. Normally what happens, there is a balance between the dopaminergic activity and the cholinergic activity. They both are balanced. The activity is balanced. But now what is the problem? The dopaminergic activity is reduced. So the inhibitory effect of the dopaminergic activity on the cholinergic activity will be reduced, and as a result of this decreased dopaminergic activity, the cholinergic activity will be increased, right? And because the cholinergic activity is increased, so there will be increased activity of acetylcholine, and this increased cholinergic activity will produce the abnormal signaling and it will lead to the loss of control of muscle movement, जिसकी वजह से tremors होना, muscle rigidity होना, ये सारे problems face होंगे. ठीक है बच्चों, इस तरीके से. तो आई होप कि आपको थोड़ा बहुत आइडिया हुआ होगा यहाँ से. अच्छा, इसमें एक और टर्म है जो कि आपने समझनी है. ये तो प्राइमरी पार्किंसनिज्म है ना, जिसमें डोपामिनर्जिक न्यूरॉन्स डैमेज होते हैं, डोपामिन रिलीज कम हो जाता है, तो डोपामिन और कोलिनर्जिक बैलेंस डिस्टर्ब हो जाता है. डोपामिनर्जिक एक्टिविटी कम, कोलिनर्जिक एक्टिविटी हाई, एबनॉर्मल मूवमेंट्स होती हैं, सिग्नलिंग होती है. But what about this term? What is secondary Parkinsonism? Secondary Parkinsonism is the Parkinsonism due to the blockade of the dopamine receptors in the brain by drugs. What was the problem in primary Parkinsonism? The neurons were destroyed, therefore there was no dopamine released. But in secondary Parkinsonism, these fibers are all good. Even the dopamine is being released, but the problem is the receptors to which this dopamine binds, those receptors are blocked by the drugs. So secondary Parkinsonism is the Parkinsonism due to blockade of dopamine receptors in brain by drugs. So in this case, the fibers are all good, dopamine is being released, but the receptors are blocked by drugs. This is said to be the secondary Parkinsonism. अब प्राइमरी में देखें डोपामिन काम नहीं कर रहा था, सेकेंडरी में भी डोपामिन रिसेप्टर ब्लॉक्स हैं, तो डोपामिन एक्टिविटी नहीं होगी. कौन सी ड्रग्स हैं जो रिसेप्टर ब्लॉक करती हैं बेटा? फॉर एग्जांपल फिनोथायाजीन हो गया, हेलोपेरिडोल हो गया. इसको हम सेकेंडरी पार्किंसनिज्म को सूडो पार्किंसनिज्म भी कहते हैं, बिकॉज दिस इज नॉट द रियल पार्किंसनिज्म. इन केस ऑफ रियल पार्किंसनिज्म, व्हाट इज द मेन थिंग? Destruction of the dopaminergic neurons in the substantia nigra. Here the dopaminergic neurons are not destroyed, okay, only the receptor is blocked, therefore dopaminergic activity is reduced and alternating cholinergic activity will be increased, right beta? Okay, now we'll talk about the treatment of Parkinson's disease, right beta? So here we go with the strategy of treatment. Yeah, so the treatment strategy is, look, what is the problem we actually discussed previously, that there is the imbalance created between the inhibitory dopaminergic activity and excitatory cholinergic activity. As I told you, in what happens in the Parkinson's disease, there is the destruction of dopaminergic neurons in the substantia nigra. So the dopaminergic activity is actually reduced, and in comparison, yeah, what happens is the cholinergic activity is increased. So this balance is actually now disturbed, right? This is the problem. Imbalance between the excitatory cholinergic neurons and yeah, a greatly diminished number of inhibitory dopaminergic neurons. So what can be the treatment strategy? You can do one of two things. Either you can increase the dopaminergic activity, or number two thing you can do is just decrease the cholinergic activity to balance. Actually, you have to create the balance between two. In the Parkinson's disease, there is actually the imbalance. There is actually the imbalance between the dopaminergic cholinergic activity. You have to reproduce the balance either by increasing the dopamine or by decreasing the cholinergic activity to the levels of the dopaminergic activity, right? Number one thing, restoring the dopamine in the basal ganglia or antagonizing the excitatory effects of the cholinergic neurons. This will re-establish the balance between the dopamine and acetylcholine. I don't think this is something very difficult. Yeah, now here you see one very easy thing, then I'll take you to drugs typically. Look, the drugs which we are going to use for the treatment of the Parkinson's disease, they do not reverse or arrest the underlying pathology. They will just relieve the symptoms, maybe temporarily. What is the underlying pathology? The underlying pathology is the destruction of dopamine producing neurons, and the symptoms are tremors, rigidity, bradykinesia. We can just increase the levels of dopamine or decrease the levels of acetylcholine, but we cannot arrest the destruction of dopaminergic neurons in the substantia nigra. Look, normally what happens, beta? Normally, you see that this is the presynaptic neuron, this is the postsynaptic neuron, this is actually the synapses. So here you see in the presynaptic neuron, this is something very interesting present here. The tyrosine molecule, with the help of tyrosine hydroxylase enzyme, is converted into the dopa, and dopa is with the help of dopa decarboxylase is converted into dopamine, right? And dopamine is obviously a inhibitory neurotransmitter. It is packaged into it is packed into the small like this synaptic vesicles में ये इस तरीके से पैक होता है, and then calcium enters into the presynaptic bulb and take these vesicles full of dopamine out into the synaptic cleft, and here we have dopamine in the synaptic cleft and it binds with its receptor and produce the inhibitory effects. What is the problem in the Parkinson's disease? Reduced dopamine levels, right? Normally this is the mechanism. By the way, normally this dopamine is metabolized by a couple of enzymes, and the metabolite is 3-O-methyl dopa, right? MAO, or you may say catechol-O-methyl transferase enzyme, COMT वगैरह. The two enzymes are there actually that can actually metabolize this dopamine into the 3-O-methyl dopa. So this is what happening in your normal life, no problem at all, right? But in case of Parkinson's disease, this dopamine levels are badly reduced due to destruction of the neurons. So what we can do in Parkinson's disease? We have to increase this dopamine. We can do it in severe ways. So many ways are there. पहली चीज़ जो है, आप बाहर से डोपामिन ला के दे दें, डोपामिन की कमी पूरी हो जाएगी. या दूसरी चीज़ हो सकती है कि ये जो एंजाइम्स हैं इनको ब्लॉक कर दें, तो डोपामिन जो है वो मेटाबोलाइज नहीं होगा, डोपामिन का डोपामिन ही पड़ा रहेगा और ये अवेलेबल होगा बाइंड होने के लिए, मेटाबोलाइज नहीं होगा. तो ये 2-4 तरीके हैं बेटा जिससे हम डोपामिन के लेवल्स को एलिवेट करके रख सकते हैं. तो राउंड को डिस्कस करते हैं वन बाय वन. चलिए, अब सबसे पहली चीज़ है, जैसे मैंने बताया कि डोपामिन की डेफिशिएंसी हो गई है. टू प्रोवाइड द पेशेंट विद डोपामिन, व्हाट्स द प्रॉब्लम देन? बट दिस इज़ नॉट इफेक्टिव. आप बाहर से डोपामिन उठा के नहीं दे सकते. वाई? बिकॉज डोपामिन कैन नॉट क्रॉस द ब्लड ब्रेन बैरियर. आपका दिल करे अच्छा पार्किंसंस डिजीज़ में डोपामिन की डेफिशिएंसी होती है, ये हमने डोपामिन का इंजेक्शन उठाया और आईवी कर दिया, लेकिन कोई फ़ायदा नहीं है, क्योंकि ब्लड में आने के बाद डोपामिन भले जगह जगह पे डिस्ट्रीब्यूट हो जाए लेकिन ब्रेन में डिस्ट्रीब्यूट नहीं हो पाएगा, बिकॉज इट कैन नॉट क्रॉस द ब्लड ब्रेन बैरियर. बट वी हैव गॉट सम अदर वैरायटी ऑफ ड्रग्स, लेवोडोपा and one of its friends carbidopa. What happens now? There is kind of an interesting thing. Levodopa is a metabolic precursor of dopamine. What happens? Let me describe. Levodopa, when you take orally or whatever route of administration prescribed, I'll talk about that in pharmacokinetics, but you understand the mechanism. Levodopa, once you have administered, it will be actively transported into CNS. Levodopa can cross the blood-brain barrier. However, dopamine cannot. So you take levodopa. Levodopa will cross the blood-brain barrier, and inside the brain, it will be converted into dopamine. Right? It will be converted into dopamine. Okay? So it's like, let me describe what's happening. So this is the blood-brain barrier. This is the substantia nigra, okay, and this is the substantia nigra. This is the, for example, limbic system, okay, and how many fibers are going from these are the dopaminergic neurons going from substantia nigra to the limbic system. You can see how many neurons are there. If let's suppose if we draw at least 5 neurons here, and out of these 5 neurons, let's suppose in Parkinson's disease there's the destruction of these neurons. Now if let's suppose these 1, 2 and 3 are destroyed, only two are left, and these 3 are completely destroyed. So what will happen, you will provide the patient with the levodopa will cross the blood brain barrier, and here it will come inside the brain, and obviously because these 3 are destroyed, so they can't do anything. The remaining 2 which are working, so they will take the levodopa and they will convert the levodopa into dopamine. Right? Now let's read here. Levodopa transported into CNS, it will be converted into dopamine. Lekin, with time the number of neurons decreases and only fewer cells are left. They are capable of converting the exogenous levodopa into dopamine. वक्त के साथ शायद ये 2 में से 1 रह जाए, ठीक है. So only 1 will be available to convert the exogenously administered levodopa into dopamine, right? The number of residual dopaminergic neurons in the substantia nigra are adequate to convert the levodopa to dopamine. 80% तो डिस्ट्रॉय हो चुके हैं, 20% काफ़ी होते हैं लेवोडोपा को डोपामिन में कन्वर्ट करने के लिए, डोपा में कन्वर्ट करने के लिए, लेकिन वक्त के साथ ये 20% भी ख़त्म हो जाते हैं, तो फिर लेवोडोपा भी काम करना छोड़ जाती है. आप लेवोडोपा देते रहें, अगर न्यूरॉन ही सारे डैमेज हो चुके हैं तो कौन लेवोडोपा को डोपामिन में कन्वर्ट करेगा. Now one more interesting thing is coming here, that levodopa must be administered with carbidopa. Why? Without carbidopa, much of the levodopa is decarboxylated to dopamine in the periphery. ब्लड ब्रेन बैरियर ये रहा आपका, ब्लड ब्रेन बैरियर के पास आने से पहले ही पेरीफ्री में ही ये मेटाबोलाइज हो जाती है, ड्रग डिकार्बोक्सिलेट हो जाती है. तो ब्लड ब्रेन बैरियर को क्रॉस करके ब्रेन में कहाँ जाएगी, ब्रेन में तो डिस्ट्रीब्यूट ही नहीं हो पाएगी इतनी ड्रग, क्योंकि सारी तो मेटाबोलाइज हो रही है. तो इसलिए हम क्या करते हैं, इसको हम कार्बिडोपा के साथ देते हैं, क्योंकि कार्बिडोपा जो है या इसको मेटाबोलाइज नहीं होने देता. अगर हम बगैर कार्बिडोपा के देंगे, विदाउट कार्बिडोपा मच ऑफ द लेवोडोपा इज डिकार्बोक्सिलेटेड टू डोपामिन इन द पेरीफ्री. पेरीफ्री के अंदर ही ये लेवोडोपा से डोपामिन बन जाएगी अगर कार्बिडोपा नहीं दोगे तो, ठीक है. इससे क्या होगा, जाहिर सी बात है, लेवोडोपा जब सारा डोपामिन में कन्वर्ट हो जाएगा पेरीफ्री के अंदर, तो इसका इफेक्ट जो ब्रेन में आना था वो नहीं आएगा. नॉजिया, वॉमिटिंग, कार्डियक एरिथमियाज और हाइपोटेंशन, ये सारी चीज़ें हैं जो कि डोपामिन पेरीफ्री में करवाएगा, ठीक है, क्योंकि डोपामिन तो बाहर ही मेटाबोलाइज हो रहा है, लेवोडोपा तो बाहर ही मेटाबोलाइज हो रहा है और फिर ऑब्वियसली ब्रेन में नहीं जा पा रहा, ठीक है बच्चों. इस तरीके से कार्बिडोपा एज ए डोपामिन डीकार्बोक्सिलेज इनहिबिटर. कार्बिडोपा अगर आप दोगे तो उसकी डीकार्बोक्सिलेशन नहीं होगी आपके लेवोडोपा की. अगर कार्बिडोपा नहीं दोगे तो लेवोडोपा पेरीफ्री में डीकार्बोक्सिलेट हो जाएगा. तो कार्बिडोपा दरअसल डोपामिन का डीकार्बोक्सिलेशन इनहिबिटर है, ठीक है. द कार्बिडोपा लोअर्स द डोज ऑफ लेवोडोपा रिक्वायर्ड. अगर आप कार्बिडोपा देते हो तो फिर बहुत ही कम मिकदार में हमें आप लेवोडोपा देनी पड़ती है बेटा, क्योंकि कार्बिडोपा इज़ रियली हेल्पफुल टू carbidopa is very much helpful to levodopa, right? When carbidopa is there, it will prevent the peripheral conversion of L-dopa into dopamine, so even a little amount of L-dopa will be enough to reach to the brain, right? And जाहिर सी बात है बेटा, जब आप कार्बिडोपा ले रहे हो साथ में तो लेवोडोपा की डोज कम लेते हो, तो इस तरीके से you get prevented from severe adverse effects ऑफ डोपामिन इन द पेरीफ्री, ठीक है. समझ आ रही है बात. अच्छा, नहीं आपसे कुछ क्वेश्चन पूछ लेते हैं, इजी करते हैं. अगर कार्बिडोपा नहीं देंगे तो क्या होगा, लेवोडोपा पेरीफ्री में डीकार्बोक्सिलेट हो जाएगा, डीकार्बोक्सिलेट होने के बाद डोपामिन में कन्वर्ट हो जाएगा. डोपामिन के पेरीफ्री में काफ़ी इफेक्ट्स होते हैं जो कि ख़तरनाक हो सकते हैं. अगर हमने कार्बिडोपा दे दिया तो ये पेरीफ्रल कन्वर्जन बंद हो जाएगी, लेवोडोपा अवेलेबल रहेगा हर वक्त और उसके काफ़ी सारे इफेक्ट्स ब्रेन में प्रोड्यूस होंगे जो हमें चाहिए हैं, ठीक है बेटा. इस तरीके से नाउ लेट्स टॉक अबाउट द थेराप्यूटिक यूजेस ऑफ द लेवोडोपा कार्बिडोपा. जस्ट अ सेकंड. ओके, इसको यहाँ फोकस कर लेते हैं थोड़ा सा. आई होप इट इज़ विजिबल. या ओके, लेवोडोपा कार्बिडोपा used in the treatment of the Parkinson's disease, no doubt. They reduce the rigidity and tremors. Obviously क्या होता है, जब आप लेवोडोपा देते हो combined with कार्बिडोपा, तो लेवोडोपा क्या करती है बच्चों, न्यूरॉन्स में जाती है, डोपा में कन्वर्ट होती है, डोपा से डोपामिन बनता है, डोपामिन एक इनहिबिटरी न्यूरोट्रांसमीटर है, इनहिबिटरी न्यूरोट्रांसमीटर क्या करता है, न्यूरोट्रांसमिशन को रोक देता है। जब न्यूरोट्रांसमिशन रुक जाएगी तो जो आपकी प्रॉब्लम थी पार्किंसन डिजीज़ में, रिजिडिटी और ट्रिमर्स, वो ख़त्म हो जाएगी। ठीक है, राइट। एंड इट रिड्यूसेस द सीवियरिटी ऑफ सिम्टम्स फॉर फर्स्ट फ्यू ईयर्स ऑफ ट्रीटमेंट, राइट। जो पार्किंसन का सबसे बड़ा मसला है, ट्रेमर्स, रिजिडिटी, वो ख़त्म हो जाते हैं, कम हो जाते हैं एक हद तक लेवोडोपा कार्बिडोपा से इस्तेमाल करने से। लेकिन प्रॉब्लम ये है कि जब आप लेवोडोपा देते हैं तो पेशेंट के जो सिम्टम्स हैं वो तो काफ़ी बेहतर हो जाते हैं पहले 1 साल में, लेकिन उसके बाद जो सेकेंड ईयर है और फॉर ऑनवर्ड जो है उसमें इफ़ेक्टिवनेस में डिक्लाइन आने लगता है। देयर इज़ डिक्लाइन इन रिस्पॉन्स during the 3rd to 5th year of the therapy, and this is said to be the wearing off phenomena. Do you understand this? You provide the patient, there is a freshly diagnosed patient with Parkinson's disease, okay? And you provide him with the levodopa carbidopa, and he is really happy because the symptoms are much better now, getting rid of the tremors, getting rid of the muscle rigidity. But in the 3rd year, 4th year, final year, 5th year, he will come to you with the same problem, maybe tremors, rigidity. He'll say, डॉक्टर साहब अभी तो ये दवाई काम ही नहीं कर रही। तो इसको हम कहते हैं वेयरिंग ऑफ फिनोमेना, ठीक है। और विड्रॉल मस्ट बी ग्रेजुअल, ऐसा नहीं सडनली इसको विड्रॉ नहीं कर सकते लेवोडोपा कार्बिडोपा का, इसके इफेक्ट्स होते हैं। तो इसलिए जब आप ड्रग बंद भी करें तो इसको ग्रेजुअली टेपर ऑफ करें, ठीक है जी। नाउ हियर विल टॉक अबाउट बेटा the pharmacokinetics of this drug, right beta? Firstly the absorption and metabolism, and then the adverse effects after that.